I think you are muted. Are you talking? Because we cannot hear you.
Sorry. Yes. Hello. Can you hear me now?
Yes, we can hear you.
All right. Bismillah ar-Rahman ar-Rahim. Allow me to start today's session and all SESMI members and participants, Assalamu alaikum and very warm welcome to a webinar arranged by Saudi Society for Medical Education, Riyadh Office, Journal Club. Let me introduce myself. I'm Dr. Shazia Iqbal, chairperson or an organizer for continued professional development activities at Saudi Society for Medical Education. Our society is very much keen to develop teaching and assessment abilities of medical faculty and educators. We encourage the firm implementation of integrated and competency-based curriculum in medical education. We believe to bridge the gap between competency-based framework and daily clinical practice among health professionals. At the same time, our concern is to ensure that medical teachers are capable enough to declare the medical graduates and trainees are sufficiently competent learners and professionals for safe medical practice in community. For that matter, we thought that let's bring interestable professional activities on the table. And you know, interestable professional activities are an emerging concept used to implement competency-based medical education. And medical educators need to enhance their knowledge about EPAs. What are EPAs and what is the basic concept when it was created? What is interestable and its importance in medical education? So the topic of presentation today is interestable professional activities, EPAs, and their significance for health profession education. I'm very much honored and delighted to present a distinguished speaker, Prof. Oletin Kate. Very warm welcome to Prof. Oletin Kate to SESMI Riyadh office. Professor Oletin Kate is PhD professor in medical education at University Medical Center, Utrecht, Netherlands, and adjunct professor of medicine at University of California, San Francisco. With a background of undergrad medical training and PhD in social sciences, he has 4 decades of experience at universities of Amsterdam and Utrecht with curriculum innovations, educational research, and faculty development in health profession domain, locally, nationally, and internationally. He was a founding director of the Center for Research and Development of Education at UMC Utrecht from 2005 to 2017. And served as a president of Netherlands Association for Medical Education from 2006 to 2012, and has published more than 450 articles and presented more than 500 presentations widely about advances in health profession education. He has successfully mentored 24 doctoral students for PhD in health profession education and currently supervises 9 candidates. For his work, he received several awards, among which the J.P. Hubbard Award of National Board of Medical Examiners and for Innovation in Medical Education and Dutch Royal Distinction for contribution to medical education. One of his interests is competency-based education in health profession and specifically the application of EPAs, interestable professional activities, and entrustment decision-making to improve education to serve the quality and safety of patient care. Before I start, I would request President SESMI Riyadh Board, Professor Khalid bin Abdul Rahman, to give some opening remarks, and then we can start with Prof. Olet. Thank you very much for joining. And Prof. Khalid, if you are around.
Yeah, without any further delay, I would like to welcome Professor Ole. And again, it's our pleasure to welcome you here in our society. And we are all keen to hear from your expertise about this topical and important issue in health professions education. So please, Professor Ole.
Over to you, Professor Ole.
Yes, thank you very much. Let me share my screen right away. Can you see my screen?
Yes.
Okay, and I'll.
Yes.
Yes, perfect. So thank you for the invitation again. And I will be talking about entrustable professional activities, the significance for health professions education in general. Let me start with just a question for the clinicians among you. Would you trust your loved ones to a trainee who just graduated and just received a certification after postgraduate training? I'm saying this because we have done a study, an interview study, and we recognize that there are many program directors who recollect cases of actually deliberately signing off for an individual who actually they would not completely trust with their own family members. And I think it's a good metaphor to, or actually not even a metaphor, it's really true, that there is some uneasiness of feeling that people then would have. So you can think that of yourself, and we actually do recognize that many program directors actually can recollect such cases. And what is the reason they actually sign off for those residents? And sometimes you can call that a failure to fail process. You're not actually stopping someone, even though you kind of feel that they are not yet ready. So very often you would say the time is up. So there's like 4 years of residency training or 5 years or 6 years. The time is just up, and then there's no, it's difficult for you to stop the learner. Or you would say there's no valid documentation to back up any failures. It might be visible, but it's never written down. So if they would ever claim that, you would probably lose that. So failing a trainee would give you trouble. And sometimes you feel you don't have tools to handle it, or when you are unsure, you would say, well, let's err for the benefit. We're not really sure, but why would we stop this trainee? And implicitly, you have to realize that you're not erring for the benefit of the patient. So what you can actually say is that the imperative of competency-based medical education is to reduce those false positive decisions when graduating trainees for unsupervised practice. So the essence of CBME, or competency-based medical education, that is to have education aimed at a standard level of proficiency for all the graduates. So critical features of CBME then is a clear description. You need a clear description of those standards. What is a good physician and specialist? And there must be assessment of all medical trainees using those standards, and to have competence and not just only time in training as a primary reason to finalize that training. Competency-based medical education has become popular, I would say, since around the turn of the century. It existed before, but since about 20 years, it's really becoming very, very popular in the world. And we have better, actually, the purposes, and we actually are creating that, of course, a better and a broader, more specific description of the standards for proficiency of physicians. And what we're doing also with CBME is to move from assuming competence after so many years to really assessing competence, and to license physician and registered specialists only when they meet standards based on competence, not just on time and training. And here you can see in the world, the most dominant models of CBME, that is the CanMEDS model on the right side, and the North American USA model of ACGME, Accreditation Council for Graduate Medical Education. They have 6 domains of competence, and the CanMEDS model has 7 actually domains or roles. Those are being used in many countries. My country used the CanMEDS model, but I know other countries sometimes use the ACGME model. Another example of what it actually means to start using CBME. Here you can see some data from a Dutch program of training of radiologists, and all our radiology residents need to take a test every half year, every 6 months. It's a mandatory test. Everybody has to take it, and it covers the breadth of radiology. And how are they doing over time? If they move from postgraduate year 1 to postgraduate year 5, you can actually see that they really nicely increase in their knowledge about radiology. And we have sophisticated tests that include, with technology, a simulation of what a real radiologist really does. So it is a mandatory test, and for many years, the test was only mandatory to take. Everybody had to take it. And you could look at your own scores. You could say, well, if I need to do better, I could do better. Now, many years ago, actually, I would say about 10 years ago, the radiologist says, we now are no longer satisfied with just that test. We want to make sure that people all pass the test. And we will set we will set a norm that is reasonable. Most of even the third year radiology residents would probably pass that test. But this is the reason why the test is important, that there is a group that we don't find acceptable to graduate if they don't meet standards. So they might need longer time in training. They have to do some more learning because we don't think they are ready, because we wouldn't trust our loved ones, our family members with that person. So CBME has actually been embraced in many countries, as I said before. There is a general acceptance. At the same time, however, if you read the literature, there is also some criticism about CBME, specifically about the detailed and analytic frameworks that have evolved over time. So since the turn of the century, most of those frameworks have been elaborated, and people have started adding things and making it more detailed. And the competencies sometimes in their description are not easily translated to assessment on the workplace. And clinical teachers sometimes struggle with assessing competencies. They have to assess competencies, and that's on their forms, but then they would see a resident and look at the form, and they cannot match the two. They are forced to give a score for something, and they don't really understand that. So what we have seen over time, that there is promise, but there's also pearls and problems, and there is some progress in competency-based medical education. But just imagine how difficult it is. You would have a trainee at the end of your rotation, as if you are the course director or you are a clinician. Just think of the domains, the general domains, and you are asked to rate every resident at the end of training on a scale, maybe from 1 to 10. How are they doing? How are they actually on medical expert, communicator, collab? You will understand that's not very easy to do. Because you have seen some things, you have not seen other things, and it's very difficult to give a reliable scores for this. There's many issues actually in workplace learning. So there is a general generosity error. We know that from the literature. Generally, scores are given too highly. There's halo effects that people would only see a little bit of a trainee and then generalize from that and give a score, a more global score that they really cannot justify, or there's a lack of reliability. So scores are not reproducible across occasions and across raters. There's unclear standards, and often people don't have standards in their mind. They don't really know how to rate. And then we know people are clinicians, observers, raters. They differ. Some people give lower scores than other people. And if you're asking an observer or a clinician, so how did you get to that rating? There could be different reasons for that. It could be proficiency of the learner, could be personal development of the learner, could be effort of the learner, could be the reference to a group performance. You could just imagine that you would say, you are not there yet, but when I look at where you came from a few weeks ago, you made terrific progress, and I will reward you with a high score. Or you've seen somebody really put so much effort making long days, and you want to reward them for that too. Or you don't want to reward them and say, well, you actually deserve a low score. And then you talk to your colleagues and hear about other students who got a high score. And then you're thinking, how can I give a low score when other people, so the reference group actually gives different scores. So that's all very complicated. And so what's needed is actually an assessment that is more easily matching with something that is really important and more easy to understand. Basically, it is much more easy to match that with responsibilities in patient care, things that are really important and really probably go through your mind as a clinician too. You would probably want a holistic and not so much a tick box approach of assessment. You want to integrate competencies and not separate them, and not just talk about this element of competence, collaboration or communication or diagnostic reasoning. And at the same time, you also want a procedure that's practically feasible. One of the really nice publications is by Jim Crossley about 10 years ago, who said, if you ask the right questions, you can expect to get reliable answers. And what you need to do is align the construct of assessment with the construct of patient care. And that will improve the workplace-based assessment skills that you use. So here is where the idea of entrustable professional activities became. To actually see if you could make assessment more closely related to patient care. So the definition of an EPA, that's a unit of professional practice, or you can think of a task or responsibility, sometimes a bundle of tasks that can be fully entrusted to a trainee once he or she has demonstrated the necessary competence to execute that activity unsupervised. The purpose of using EPAs is to operationalize competency-based medical education so there are stepwise and safe engagement of trainees in the clinical practice with progressive and, be it bounded, but progressive autonomy. And if you would define becoming competent, that would actually, you could equate that to passing the threshold that allows for sufficient trust in the trainee to act unsupervised. If you and your team really trust that learner to take care of your own patients, maybe even your own family members, then that can be expressed as a trust. And if you do that for a learner, of course, a learner after their training period, they will still increase in their competence, but they pass a threshold. And if you all agree that based on what you've seen, based on your observation and assessment, you can actually make that decision to say they can now work unsupervised. So again, an EPA is an entrustable professional activity. So entrustable means that it's an act that requires trust by colleagues, by patients, by the public. It is professional. So an EPA is always something that is linked to a profession. It's confined to occupations with an extraordinary qualification. You must be able to say, this EPA, you're not allowed to do that yet. But after we all confirm that we can trust you, you may be allowed to do it. And it's activities. So it's not a competency, but it's an activity, a task that must be done, or could call it a responsibility that must be carried out. So EPA's ground competencies in daily practice, they break the medical practice down in units that can be overseen, assessed, monitored, documented, and certified. You can just imagine when you graduate a person or give them a license, that's the big EPA. The license is actually the huge EPA, because from then on, you're trusting a person to actually carry out patient care, or a certification for a specialty, to be a specialist and to have the breadth of the specialist. But there's usually not a single person who can oversee that whole breadth. So that's why we break that down into units. And for each of these units, it's much more easy to say, well, do we now trust you to do that domain, that unit of practice? So again, many people come back and start asking, what's the difference between competencies and EPAs? Now, here, this picture tries to make that difference. So competencies really are descriptors of persons. Every person has their competencies. People could be competent in music, in chess, in medicine, sports, other things. So that is the possession of knowledge, skills, attitudes, values, things that we cannot see from outside that are in your possession. You can do it. You have content expertise, you have health system knowledge, communication abilities, all those things that describe a person. And if you have that if you have that in sufficient amount, you may be able to graduate. Now, the EPAs are not linked to individual persons. It's just the work that must be done. It is a script of it's essential work. If you run a hospital, there's many things that must be done. Every department has many things that must be done. Even smaller units, every day, Monday morning, 8 o'clock, so many things that must be done. And you're hiring personnel actually to do many of those things. And you want to hire people that are competent to do so. They need competencies, but then they're asked to do the work. So EPA is actually the work that must be done. So if you look at the dictionary, the Oxford Dictionary says a competency is an ability to do something successfully or efficiently. You can find that in the dictionary. And if you think of an EPA, and that's something that is being done successfully or efficiently, or you could say trusted to be done. That's the EPA. So that leads to pictures like this. So if you run a hospital or department, there's tasks to be done, and you're looking for persons with a competency profile that fits the profile of the task that must be done. And in that sense, you can actually look at EPAs and competencies as two dimensions of a grid. And the grid is actually about clinical education. At the end of the day, you want this person to be able to do EPA 1 and 2 and 3 and 4 and 5. And for each of these EPAs, if you really think about it, it's almost invariably needed that people combine competencies, combine expertise, collaboration skill, communication skill, and everything in that EPA. So there's hardly anything in healthcare you can think of that does not use at least 2 of those domains. So what's better actually is to focus your assessment on EPAs, rather do that than focus your assessment on individual competence and try to separate out those competencies. It's going to be very difficult. Just focus on, is this person able to do this work? At the end of the day, that's anyway what you would like to know. And in that sense, if you look at competency frameworks, many competency frameworks have started to define what a doctor is, define it in roles, like 7 roles, and then usually define it even more detailed in sub-competencies and enabling competencies, key competencies, many, many, many things. And there's whole documents that define what those competencies are. And until you really lose track of it, you cannot oversee that anymore. So what EPAs do is actually they bring them back, and EPAs actually are more of a synthetic and not so much a holistic framework. Or it is holistic. I mean, it's not analytic, but it's a synthetic framework, a holistic. Now, if we have that in mind, we can think about how would you define that somebody is competent? And then you could say when an EPA professional activity is mastered at a threshold level that permits trust to act unsupervised. So that's actually a stage in a developmental framework. So if this is the development of competence over time, so the horizontal axis is the time, the vertical axis is competence, you could see that people progress over time. And you could, if you want to, you could put a framework on that, say, how do you call people who start that were novices, then they become advanced beginners, then you could say they become competent, they become proficient, then they become expert. That's the framework. That terminology is from Dreyfus. And if you think of it, the Dreyfus framework actually uses that word competent in the middle of their framework. And it's actually very elegant to do that, because we could say to learners, we call you competent at the moment that we can all, as a team, trust you to work unsupervised. And you could say that for one EPA, but you could also say that for another EPA, and you could see that EPAs are not just as easy. Some are more easy, some are more difficult for the learner. And some you would not even start training in the first year of their training or their residency. There's another very easy one. If you draw that line of threshold of competence, it is very unnatural to think that all EPAs are reached at the same point, I would say at the last day of training. Of course they are not. They are actually, they are met at different points in training. There's different moments in training that you would actually be able to say, this is the right moment for an entrustment decision. There's a justified entrustment. We can do that. And from then on, we allow you to do this work unsupervised. And you're becoming gradually our colleague. You're a trainee for some EPAs, but you're no longer really truly a trainee for some other EPAs. So you could even imagine there could be an EPA that you would qualify a person as ready for unsupervised practice. Then your training is over. People start developing for many EPAs until higher levels of proficiency. But for some EPAs, they may not ever work in that area anymore. So if they're not practicing, maybe after numbers of years, we would not want to trust them anymore. So there could be a loss of trust at a certain point in time. And if you think of that, we now talked about unsupervised practice or supervised practice. And of course, in a training program, you have more detailed framework and levels of entrustment. And we usually use a 5-level entrustment. There are different frameworks for that, but this is a very helpful framework, and many people use that. So you start as a learner to be present that's already in a decision. Not everybody can be in the healthcare space or in the operation room or somewhere else, but you're not yet allowed to enact an EPA. Second level would be you're now allowed to do that, but there must be someone who carefully watches you, maybe work with you, give you proactive supervision, but you're now allowed to do something. Level 3 would be you're also allowed to do something when nobody is present in the room in exactly the space and watching you. They should be actually available quickly if you need help. So that is reactive supervision. You're reacting to a request for help and provide supervision when needed. And then you have that threshold level, a threshold for unsupervised practice. So as a supervisor, you're not available, or definitely not quickly available, maybe over the phone, maybe on a distance, but you are ready for unsupervised practice, like somebody who has completed training. And if you develop further, you might be so proficient that you might provide supervision, be the supervisor for a junior learner. So this is what observation only looks like. You're in the space, you're even with the clothes that are attached to your status of a medical student, maybe. Here's direct proactive supervision. The supervisor is actually behind the learner for this endoscopy. Here's level 3. So level 3 is you've done this by yourself, but you're reporting back to a supervisor, and then together you could look at whether you did this well or not. Here's oversight only, distant supervision. That might be in a night shift and there's not a supervisor nearby. You may be even be able to call someone from their bed, but most of the work you actually have to solve by yourself. It's actually distant oversight. Or you could provide supervision to a junior learner, to a medical student or a junior resident. So if you think of EPAs and you build a curriculum with EPAs, this is what a curriculum could look like. What it basically says is there's an individualized workplace curriculum with 5 levels of supervision for different EPAs, and for a trainee Jones here in a program with 4 postgraduate years, you could say you start at level 1. For some EPAs, you don't start at level 1, you start at level 2, or even start at level 3 sometimes. And then you progress until you have reached level 4, because that's the level you are ready for unsupervised practice. You do that for a while, you might get to level 5, and that could be different moments in your training. For some EPAs, you may be qualified to do that work from the postgraduate year 2. We're just doing a study at this moment among our dermatology programs in the Netherlands are all EPA based. And we're looking whether people have their first EPA in their training, they should be able to get after about a year of training. Do they really get that autonomy? So that's important. So if you think of growth of competence, just the picture that I showed before, you could just imagine that there's shades of supervision, from observation, direct supervision, indirect supervision, distant supervision, and really no supervision. And the key element here is actually that a summative entrustment decision can mark the difference between indirect supervision and distant supervision, or no, actually ready for unsupervised practice at level 4. But then there might still be a period in training that you still can work with responsibilities at level 4. And that's important because traditionally, and some programs still have that, will never have a learner work by themselves until the end of training. But you have to realize, if a learner has never had that experience of working by themselves, they will probably be scared to death after training when they start and suddenly have all the responsibilities. So what you better can do is look at EPAs for those things that they're ready, and just have them work and in training and have that experience of responsibility. Now, if you think of it that way, and in entrustment decision making, we have a slightly different approach to how we look at assessment. In most higher education, actually most education, people would say, teachers would say, give assignments to students, and if the students complete their assignments, they're marked off. And if they did well, you could look at how they did, give a high mark, and just add everything up, and then they're ready to get the diploma. That's fine. And we would call that actually a retrospective approach to assessment. It's just answering the question, does the student show mastery of the content taught in the courses? Did they do everything we said they should do? And also in rotations. Now, what is good to realize that when you're working with entrustment decisions at the end of training, what's more important, to just state that they did everything you wanted them to do, or are they ready to assume expected future responsibilities? And you have to realize that is something different. It's not exactly the same thing to just say we saw everything and we marked off. But in the future, there might be things that you've not observed, but you're trusting the person to have that responsibility and to know what to do if they run into something, even something that may have not been in training. So if you compare the psychology of traditional workplace-based assessment, and you could just see a learner here, and a learner by themselves thinks, well, please mark me as superior people, or student like that. And then as a supervisor, you might think, she's nice, she works hard, and I don't know what mark I shall give, but it won't hurt, and it will probably motivate her if I mark her as superior. So you might recognize those situations, and it's a nice person, you really like her, and you think, well, it'll probably be motivated. Let's give her a pretty good score. But that's a different thinking from the prospective thinking that we now think when we use EPAs. And you could think, well, she's nice and works hard, but will I trust her with that EPA? It may hurt my patience if I mark her as ready for unsupervised practice. Now, suddenly, in the assessment equation, the patient is an element. It's not just what the student has done, but it's really, are they ready to take responsibility for patient care? That's a different decision. That's more what Jim Crossy would call an alignment of your assessment and patient care. And if you make addressment decisions, you have to realize what the trust concept really means. Trusting someone is actually making yourself vulnerable. If you would say, I have patience, but I leave the room now and I trust the student will take care of them well, and I'll ask the student to report back. It's actually your responsibility. But so you are vulnerable if you trust your learners to do things for your patients, and you are accepting a risk. There's always a risk. There's no situations that there's no risk at all. So, but you are now accepting the risk, and you're accepting the risk that adverse events could happen. And you have to realize that graduates will be certified for activities that supervisors may not have observed. You cannot observe everything. It might even be true that learners may have not even encountered everything that they are supposed to be able to do. So in that whole trust concept, you want to just have enough observation that you can just say, now this learner, I've seen enough, now I can trust that learner. If you think of your own kids and you think the first time you say to a kid, go to the grocery shop and get some groceries for myself, for our family, you're trusting your kid to do something that, yeah, something could happen on the way, but you're trusting your kid to do something. The same holds for medical students too, and for residents. So trust and trustment decisions require some sort of estimation. You want to have that gut feeling of adaptive competence that they have. Adaptive to cope with unfamiliar situations. You just want to make sure they stay out of trouble. That's important for patient safety. So trust involves more than the average or the past performances. So that's why it's different to just look at how did they do, just average out everything they did and make some score and then say you're passing because your average score is like satisfactory. Here you can see two learners with different scores over a period of 10 observations in the past. So the average score of learner blue, learner one, the average score is 2.1 on a 10-point scale, and with positive and negative, it's even from -10 to +10. If the average score is 2.1. For learner two, the average score is 1.9. So that's actually lower. Now, if you look at those two learners, who would you trust to for the next observation, next critical? Who would you think, well, I can now leave? And you could see learner two actually did maybe not on average as good as learner one, but very consistent. They were always sufficient. So that may be more important than averaging out all our observations in the past. So if we think about entrustment decisions, we might also think, is reporting what a learner does really the highest level of assessment that we should aspire? We might think somewhat differently about that. We might think there might be something on top of Miller's pyramid. Miller's pyramid is very famous for those 4 levels. Now, if you think of Miller's pyramid, let's go from the bottom. The nose level is that we would assess them on their knowledge. The know-how level is on their applied knowledge. We could do that with written examinations and everything. It shows how it's usually knowledge and skills integrated in a skills or an OSCE exam. The does level is knowledge and skills and attitude integrated and observed in the context, but only observing in a context and then marking that may not be enough. We want to estimate, are they ready for future demands? And there's more than just an observation that is into that equation. Just imagine, here's a clinician, and that clinician thinks about we're thinking of what are the factors. that determine that entrustment decision. Can I trust this learner to attend to this patient now? And you just imagine you're standing there, if you are a clinician, here's the patient is pretty sick. And now, are you ready to go out of the room and trust that learner? So just think of just this thought, and you'll just recognize there's more things than just an observation. We call this an ad hoc entrustment decision. The ad hoc decision is, I'm leaving the room. So I'm leaving the learner alone. That's an ad hoc decision. We say to the learner, you can do it by yourself, report back to us. Can I trust this student to attend to this patient now? If you look at that sentence, there's 1, 2, 3, 4, 5, 6 elements actually in it. And we have to realize that we know from the literature and studies that ad hoc entrustment decision, there's many factors that come into that equation. It's the trainee, the supervisor, the task, the relationship between the trainee, the supervisor, and the context. So can I, which is the supervisor, trust this student, that student, so the trainee, of course, is important, to attend to this patient now. So what is attending to the patient? What does it mean? What is the activity really? And to this patient, so it's different from another patient. So that's into the task. And the context is, can I do that now? Because I know there's a nurse around, so there's not a big calamity, but it may be different in the night shift. So there's many factors. And if you think of all those factors, I'll come back to this, the trainee factors. Trainee factors are important. It's not just competence, but there's a whole series of things. And I'll come back to that. Supervisor, of course, the clinical, we know from studies that clinical experience is important. Clinical ability, are you a very good clinician? Trust propensity, some people tend to trust better than others, or supervisory experience is important. The task is important. So the difficulty of the task, what are the risks that are involved? The context is important. Is our qualified personnel around? What's the time of the day? How much hands do we actually need? Is it COVID time and we need all the hands we can get? We might make a decision more readily than in other cases when there's not so much urgency. And of course, the relationship is important. There's like-mindedness, there's duration of the acquaintance. There is the culture on the ward is important. So if we go back to the trainees, just think of those general qualities that enable trust in trainees. We summarized the literature about that, and we came to 5 factors. One is capability. So what is the specific knowledge and skills and experience and awareness and oversight that relates to that one EPA? Then there's integrity. That's the more general element. So is the learner truthful? Can I trust the learner when they report back? Do they have good intentions? Is benevolence? Are they patient-centered? Are they reliable? Do they have predictable behavior? Are they accountable? Are they responsible? Are they conscientious? So remember those graphic with those 2 different learners. One is more reliable than the other because they have more stable behavior over time. Then there's humility. Humility really means that, are you willing to observe your own limitations? Are you willing to ask for help? Are you receptive to feedback? Not only feedback from the supervisor, feedback from anyone, from the nurses, from your peers. An agency, that's also important. Are you sufficiently self-confident? Do you have a proactive attitude towards work and team and safety and development? And the funny thing is, and when we wrote this paper with Carrie Chen, we didn't even realize that there was a really nice acronym. So somebody actually pointed us at the acronym. If you juggle those words around, you can think of a rich entrustment decision, just to remember those elements of agency, reliability, integrity, capability, and humility. So how do you translate that to a curriculum? So if you have a curriculum, most curriculum, you have like 4 stages. The first stage would be like classroom and self-directed learning. Second stage would be in a simulated environment. You're training people to do things integrated. And then you have a supervised training in clerkships and in residency. And the final stage is also unsupervised practice. And even in an early phase of unsupervised practice, there's still much learning happening. So, and actually, of course, many of these things overlap. So in classroom training, it's mostly about knowledge. Your education is like explanation, group facilitation. What a teacher does, what a student does is direct, self-directed learning and receive direct teaching. Assessment is usually written on online assessment. The focus of assessment is knowledge, skills, attitudes, competencies. That still holds for simulation. But there's also, then the focus, of course, is on skills. Teaching is usually instruction and feedback. And student activity is doing, practicing preclinical practice all the time. Assessment is very often the rating of observed behavior, such as in an OSCE. And then there's the third stage in the clinical space, supervised training. That's what the category is really on clinical performance. You're looking at how do they go about in true clinical patient care. And clinical instructing by a preceptor is important. The student activity is actually providing patient care and developing proficiency. The assessment procedure could be entrustment, summative entrustment, decision-making. And the focus of assessment could be on those activities, competencies, and EPAs. And in the final stage, even after training, unsupervised practice happens. Clinical performance is important. There's self-directed learning, completely self-directed. There's patient care. There might be peer review for entrustment. So I think it's important to continue to think about EPAs also in postgraduate training and in CPD when people are after training. And of course, those stages are not completely separated. Of course, you would, in supervised training, you might go back and get some more new knowledge or go back to a skills lab to train something very specifically. Even if you're in practice, you might go back for some training for specific things that you have not yet acquired. This, of course, is our focus on using EPAs. They are most important in the phase of clinical phase and even after the clinical phase. Now, how do you go about when you want to assess people on EPAs? And the flow of workplace-based assessment usually is have people practice specific things, observe them, evaluate them, provide feedback, and multiple times make an ad hoc entrustment decision and evaluate it afterwards. All those observations can be, if you have that system in place, like a portfolio, can be documented in a portfolio. And before you really make the important decision, we call that a summative entrustment decision by a committee, and very often you call that a clinical competency committee, but it's sometimes called an entrustment committee. They use the data, all the data they can get about a learner and make that important decision, and now say for that EPA, you're moving to the next stage of responsibility. So that is a distinction between ad hoc decisions that happen every day and that must be evaluated, and the summative decision that actually says, in this statement of awarded responsibility from tomorrow, we will allow you for this EPA with those limitations at this level of supervision to perform. And sometimes it's called a STAR, that statement of responsibility. Sometimes people start even put their signature. And if you put the signature, you suddenly realize what importance that is, that you actually really trust that learner. So summative entrustment decisions must have serious consequences. That is important. If you use EPAs, it means increased responsibility is decreased supervision. Summative entrustment decisions without structural consequences, actually, I would say are toothless or ineffective. I see sometimes that happening. People would say, we'll use EPAs and we call them entrustment decision, but it makes no difference for the learner if they are trusted at level 4. And so increased responsibility boosts motivation and learning too. We have to realize that if you really do that carefully well, learners will really appreciate it and be motivated. Schools and postgraduate trainings must define what that is, increased responsibility. And then EPAs are excellent to operationalize progressive responsibility. Increments in rotations could be happen during or after rotations per semester or per year. So here's an overview of what that looks like. So if you go from bottom to top, here's undergraduate training and postgraduate training. Of course, you have courses, you train people in knowledge, skills, attitudes, you make them ready to start working with EPAs, and then make decisions about supervision, usually from level 1 to level 3 in undergraduate and to level 4 in postgraduate. However, in some countries, there are actually more countries than you would think of, that people don't always go to postgraduate training. Some people go to primary care, sometimes in rural areas, sometimes unsupervised practice. Their scope of practice may be different, but sometimes you have to have EPAs qualified at level 4 unsupervised practice at the end of undergraduate training. So some take-home messages after a long talk: CBME is to decrease false positive graduation decisions. That's one way to operationalize that. EPAs focus on the education, the assessment on activities in patient care. Supervision, it is important to define levels and to take these seriously. Summative entrustment decisions, give them teeth. So make them truly important, and build an EPA continuum of medical school and residency, and probably also afterwards. So that was basically my last regular slide. For those who are interested to learn more, I just want to point them at a simple website, if you want to remember, epa-courses.nl. You can learn about courses that we have, multi-day courses, to get the details of all the ins and outs of entrustable professional activities. And I'm looking at my watch. There's one thing that I have left, but I will probably skip that. There's a 3-minute animation to show how you can use EPAs in practice. It's from a dental school. I will not use it for now, but if you are interested, because I think we're heading towards, we need a little bit of time for discussion. Yeah, if you really want to, you can find that. If you look at dental education in the Netherlands with EPAs, you can also find it on YouTube.